This video recording is Anatomy and Physiology of the Male and Reproductive Systems, Part 2 of 2. We talked about spermatogenesis, and as you'll recall from spermatogenesis, we started out with a special cell called a spermatogonium, which is singular for spermatogonia, and the process of meiosis created tetrads which divided, and at the end of meiosis 2, our final product was 4 haploid cells. So we got 4 haploid cells from one original spermatogonium. Let's look at the key differences between oogenesis, which is the creation of an ovum, and spermatogenesis, which is the creation of sperm. First, we have a production of primary oocytes that occurs only in the fetus. Remember that the spermatogonia for the male can be produced throughout his life in the seminiferous tubules, but it only occurs in females when that growing individual is in the womb. And in primary oocytes, meiosis is going to be arrested or stopped in prophase 1 and only resumes years later, if at all. In secondary oocytes, meiosis is arrested in metaphase 2 and is only completed if fertilization occurs. So again, spermatogenesis will produce 4 haploid cells. Oogenesis produces 1 mature ovum, and at birth, a female is presumed to have a lifetime supply of primary oocytes. When we talk about oogenesis, it's the production of female gametes, which are eggs or ova. Just like in the male, we had spermatogonia, which are diploid stem cells. In the female, we've got oogonia, which are diploid stem cells that will divide by mitosis to produce primary oocytes. And before birth, there are little areas known as follicles, and specifically primordial follicles, that are already present in the ovaries and contain primary oocytes that are arrested at that point in prophase 1. And so the primordial follicle contains a primary oocyte. It is surrounded by simple squamous epithelium that makes up follicle cells, which are sometimes also referred to as pregranulosa cells. And throughout life, all the way up until menopause, those primordial follicles will begin to grow and develop. So if we look at the primordial follicle, as the cells around the primordial follicle send chemical messages to themselves, they are going to send chemical messages to enhance their own growth. So they're acting as paracrine glands. The primary follicle will develop from the primordial follicle. The difference between the two is the primordial follicle is made up of simple squamous epithelium. A primary follicle has morphed into a single layer of simple cuboidal epithelium. And as those cells continue to develop, they'll start to undergo mitosis as well. And we see layers of cuboidal epithelium. So now we've got stratified cuboidal epithelium that make up what we call the secondary follicle. And when we've got those layers of cells in the secondary follicle, now we've gone from pregranulosa cells to granulosa cells. Now understand that primordial primary and secondary follicles all contain primary oocytes that are arrested in prophase 1. So if we look on the right side of this picture in this chart, we can see that we start with that stem cell, the oogonium. It undergoes mitosis to create a primary oocyte, and that meiosis is now going to begin, but it gets arrested and stops in prophase 1, so it's not going anywhere. When a female is born, each ovary contains approximately 500,000 to 1,000,000 primordial follicles, each distinguished by a single layer of squamous-shaped pregranulosa cells surrounding a primary oocyte. And prior to puberty, a lot of those primordial follicles are going to undergo atresia, where they die off. And that will happen to a little over half of the primordial follicles. The remaining primordial follicles will continue to exist. However, a lot of those will continue to die off even after puberty. So they don't all remain there as a woman ages over time. When puberty occurs, a select few of those primordial follicles, approximately 20 of those primordial follicles in each ovary, will start to develop into primary follicles. And this development from primordial to primary will occur every month, where approximately 20 primordial follicles will develop into primary follicles in each ovary. The primary follicles still have a primary oocyte, and now they are distinguished or characterized by having a single layer of cuboidal-shaped pregranulosa cells surrounding that primary oocyte, which is now going to start secreting a glycoprotein-rich zona pellucida. So it's got a clear layer of glycoprotein around itself, that primary oocyte. From there, the primary follicles will begin to develop into secondary follicles, which are characterized by multiple layers of granulosa cells and an outer layer of thecal cells, which are both capable of producing estrogen. It's also at this time where groups of cells will start to surround the primary oocyte and its zona pellucida, forming a radiating crown called the corona radiata. From secondary follicles, the follicle will then develop into what's known as a tertiary follicle, or a vesicular follicle, or an antral follicle, where the oocyte with its zona pellucida and corona radiata is now going to be contained in a fluid-filled space, which is the antrum of the follicle. And it's still connected to a wall of the follicle by a little stalk. With the tertiary follicles, one of those tertiary follicles will be stimulated to undergo ovulation, and so it becomes what's referred to as the dominant follicle. However, just before the dominant follicle undergoes ovulation, that primary oocyte inside that vesicular or tertiary or antral follicle will resume the process of meiosis, and it will turn into a secondary oocyte prior to ovulation. Follicles basically have one of two fates. Most follicles, even as primordial follicles, will undergo a process known as atresia, which is going to include apoptosis of the cells that make up the follicle, as well as the primary oocytes within those primordial follicles. So those cells will undergo apoptosis or programmed cell death, and even before puberty, approximately half of all of the primordial follicles that were initially created and with which the female was born are going to undergo atresia even before puberty. During the rest of the female's reproductive lifespan, those primordial follicles are going to slowly continue to undergo atresia. So by the end of that reproductive period, a woman has ovulated approximately 500 ova. So 99% of all follicles are never recruited to develop from primordial follicles into primary follicles. Approximately 20 primordial follicles will develop into primary follicles each month from each ovary. And if they're recruited, they have the potential to undergo the process of ovulation, and only one ova is ovulated each month. So through that whole process, if ovulation is to occur, that's going to occur once a month after puberty, and it's caused by high hormonal levels, especially luteinizing hormone. There is some follicle stimulating hormone involved in the process. We'll take a closer look at that. And only one follicle from that group of 20 or so on that ovary is going to be selected each month to become the dominant follicle. Now, a dominant follicle contains a primary oocyte that will resume meiosis 1 just prior to ovulation. So if we look at the top of this picture, you can see that at the end of meiosis 1, there is a cell just above it that has a little spindle process sticking off of it. That spindle process is a portion of the cell that contains DNA, so that when meiosis 1 is completed, as the DNA is separated, that little spindle forms a first polar body and a secondary oocyte. So that first polar body and secondary oocyte are created when we had a tetrad of chromosomes. Okay, here's one chromosome, and if we have two homologous pairs buttoned together in synapsis, we're separating those chromosome pairs. So we'd have, I don't know if I can do this with my fingers, we'd have two homologous pairs now separated, and the first polar body contains contains that separation of the homologous pairs of chromosomes. So now we see chromosomes in the first polar body, and the spindle came off of that primary oocyte to develop that first polar body, and it also develops a secondary oocyte that's got the majority of the cytoplasm from that primary oocyte. So it's got the cytoplasm, the organelles, because this is the one that is eventually potentially going to be fertilized by sperm. Now that secondary oocyte is going to be something that is developed just prior to ovulation. And then once ovulation occurs, what happens with that first polar body is it may actually go through the process of meiosis 2, where it divides and the chromosomes split apart into sister chromatids, generating for more polar bodies. It may or may not do that. Either way, all polar bodies are going to degenerate. The secondary oocyte that has completed meiosis 1 is now arrested in metaphase 2. And you'll notice there's also a little spindle attached to it. And that spindle has the DNA inside of it. So what happens is with that secondary oocyte, it's arrested in metaphase 2. And in that process of metaphase 2, we've got yet another spindle where that can be a way to extrude excess DNA if it is penetrated by a spermatocyte, a sperm cell. Now, meiosis 2 is only completed, this division of DNA is only completed if that sperm penetrates the oocyte. So secondary oocytes are going to arrest in metaphase 2, and that is the cell that will become the ovulated ovum. If it's not penetrated by a sperm, if it's not fertilized, it will very simply deteriorate. However, if it is penetrated and fertilized by a spermatocyte, then that secondary oocyte will quickly complete meiosis 2. And when it completes meiosis 2, it is going to yield an ovum, which is a large cell with enough cytoplasm to nourish that fertilized egg on its 6 to 7 day journey to the uterus, because most ova are fertilized in the uterine or fallopian tubes. That meiosis 2 also produces a second polar body, which is a small cell lacking cytoplasm but containing DNA, and that second polar body will degenerate and die. Because remember that that secondary oocyte has DNA that still needs to be separated in meiosis 2, and that's where that second polar body is generated from the spindle on the secondary oocyte. Now, in terms of follicular development, follicles and oocytes can take nearly a year to mature before ovulation can occur. So the maturation process occurs in two distinct phases. The first phase is what we refer to as gonadotropin independent, or the pre-antral phase, that involves intrafollicular paracrines. So the paracrine cells are basically the follicular cells. They produce chemicals that will cause them to increase in number, and they're paracrines because they're acting on each other nearby. And this is true. The gonadotropin independent pre-antral phase is going to be what we see for primordial follicles, primary follicles, and secondary follicles. However, phase 2, the antral phase, is going to be a phase that stimulates the secondary follicles to turn into tertiary or antral or vesicular follicles by the stimulus provided by follicle stimulating hormone and luteinizing hormone. So the secondary follicle stage ends when liquid accumulates between the granulosa cells, forming that early vesicular follicle, and it's in that tertiary stage where we've got those approximately 20 follicles that are developing. It's in that tertiary stage where a dominant follicle will be selected, and if once that dominant follicle is selected, that primary oocyte will resume meiosis 1, and that's where we see that fluid-filled antrum. That's that cavity within the follicle. So the secondary follicle becomes a vesicular follicle, or antral follicle, or Graafian follicle, or tertiary follicle. I'm going to add another name by saying Graafian. Graafian is another way to describe this tertiary follicle. And the antrum will continue to expand with fluid isolating the oocyte and its surrounding corona radiata. And remember that the corona radiata is still going to sit on a stalk on one side of the follicle, but when that follicle size reaches about 2.5 centimeters or an inch in diameter, as it bulges on the external surface of the ovary, it's at that point where the ballooning of that wall of the ovary will cause it to rupture, expelling that secondary oocyte with its corona radiata into the peritoneal cavity. And when a woman feels a twinge of pain on one side or the other, that's an experience that is referred to as Mittelschmerz. My mother could always tell from which side she was ovulating on each month. And it's not felt by every woman, but if there's a twinge of pain during day 14 of a woman's cycle, again, that's what we refer to as Mittelschmerz. Approximately 1 to 2% of ovulations will release more than one secondary oocyte. So it's very, very rare. But if it occurs, and if that other secondary oocyte is fertilized, that's going to result in fraternal twins, because they're 2 different eggs, 2 different sperm. However, identical twins result in fertilization from one oocyte, which then accidentally splits into 2 daughter cells. In some women, oocytes may be released at times completely unrelated to hormone levels. Immediately after ovulation occurs, that ruptured follicle will collapse and the antrum, the space, will fill with clotted blood. At that point, it's referred to as the corpus heragicum, and that clotted blood will eventually be reabsorbed. The remaining granulosa cells and their surrounding thecal cells will actually begin to enlarge, forming a corpus luteum, which means yellow body. The corpus luteum will begin to secrete progesterone and some estrogen. If no pregnancy occurs, that corpus luteum will degenerate into a corpus albicans, which is a whitish appearing scar tissue, in about 10 days. And this is what we refer to as the luteolytic or ischemic phase, which is the last 2 days of the luteal phase, where the endometrium begins to erode. So the luteal phase, luteal means pertaining to the luteum. So again, the luteolytic or ischemic phase, the last 2 days of the luteal phase, where the endometrium, which is the inner lining of the uterus, begins to erode. Now, if pregnancy were to occur, that corpus luteum would continue to produce hormones that would sustain the pregnancy until the placenta takes over, and that takes about 3 months to occur. So the corpus luteum does have a very big job if that ovum is fertilized. Before puberty, the ovaries actually secrete small amounts of estrogen, which inhibit hypothalamic release of gonadotropic releasing hormone. As puberty gets closer, and if leptin levels are adequate, remember leptin is a hormone stored in adipose connective tissue, then the hypothalamus becomes less estrogen sensitive, so gonadotropic releasing hormone is released, stimulating follicle stimulating hormone and luteinizing hormone release from the adenohypophysis, which then acts on the ovaries. These events continue until an adult cyclic pattern is achieved and menarche occurs. Menarche is the onset of menses. It's the first menstrual period. What happens in terms of hormonal interactions during the ovarian cycle is that gonadotropic releasing hormone stimulates the secretion of follicle-stimulating hormone and luteinizing hormone from the adenohypophysis. The follicle-stimulating hormone and luteinizing hormone both act to stimulate the follicles to grow, mature, and secrete sex hormones. Follicle-stimulating hormone stimulates the granulosa cells to produce and release estrogen, and the luteinizing hormone will stimulate thecal cells to produce androgens, which the granulosa cells can then convert to estrogens. Essentially, follicle-stimulating hormone causes sperm production, and causes the maturation of ovarian follicles. Negative feedback occurs to inhibit gonadotropic releasing hormone when increasing levels of plasma estrogen exert negative feedback inhibition on the release of follicle-stimulating hormone and luteinizing hormone. So the elevated estrogen levels can act on both the hypothalamus and the adenohypophysis. Remember that the granulosa cells can also produce a hormone known as inhibin, and inhibin from the granulosa cells will also inhibit the release of follicle-stimulating hormone from the adenohypophysis. Only the dominant follicle can withstand this drop in follicle-stimulating hormone. Other developing follicles will begin to deteriorate. Positive feedback stimulates gonadotropin release. So as estrogen levels continue to rise as a result of continued release of estrogen from that dominant follicle, when those estrogen levels reach a critical high value, there is a brief positive feedback that occurs on the hypothalamus and the adenohypophysis. That triggers a surge of luteinizing hormone, which causes ovulation to occur. That luteinizing hormone surge will trigger ovulation and the formation of the corpus luteum. So high levels of estrogen trigger the release of stored luteinizing hormone and some follicle-stimulating hormone by the adenohypophysis or anterior pituitary at mid-cycle. That surge triggers ovulation. The luteinizing hormone surge triggers the primary oocyte to complete meiosis 1 to become the secondary oocyte. The secondary oocyte then enters meiosis 2, continuing on to metaphase 2. Remember, it's arrested in metaphase 2 unless it is penetrated by a spermatocyte. The luteinizing hormone also stimulates other events that lead to ovulation, including an increase in local vascular permeability. It also triggers an inflammatory response that promotes the release of metalloproteinase, which those enzymes will weaken the ovarian wall to allow that rupture to occur. The metalloproteinase enzymes also stop blood flow to the protruding follicle wall, causing the wall to thin, bulge, and rupture, forming a hole. And then that oocyte with its corona radiata will exit the ovary, accomplishing ovulation. Shortly after ovulation, estrogen levels decline. Luteinizing hormone transforms that ruptured follicle into the corpus luteum. Luteinizing hormone stimulates the corpus luteum to secrete progesterone and some estrogen almost immediately. Progesterone helps maintain the stratum functionalis of the endometrium of the uterus. It maintains pregnancy if pregnancy occurs. Negative feedback from rising plasma progesterone and estrogen levels will inhibit the release of luteinizing hormone and follicle-stimulating hormone. The corpus luteum and granulosa cells also produce a hormone known as inhibin, which enhances the inhibitory effect. Declining luteinizing hormone will end luteal activity and inhibit follicle development. If no fertilization occurs, the corpus luteum will degenerate into the corpus albicans when luteinizing hormone levels start to fall. This causes a sharp decrease in estrogen and progesterone, which in turn ends up blockage of the secretion of follicle-stimulating hormone and luteinizing hormone, causing the cycle to start all over again. The oocyte is actually activated 12 months prior to ovulation, but matures within 14 days before ovulation. The menstrual or uterine cycle involves a series of cyclic changes in the endometrium that happen in accordance with the fluctuation of ovarian hormones. There are 3 levels to the menstrual cycle. Keep in mind that a menstrual cycle is a cycle that occurs every 28 days. The first 5 days, days 1 through 5, is the first of the 3 phases, which is known as the menstrual phase. This is when menstrual flow is occurring because the functional layer, the stratum functionalis of the endometrium, is shed. Days 6 through 14 are known as the proliferative or pre-ovulatory phase because this is where the functional layer, the stratum functionalis of the endometrium, is rebuilt. The last portion of the menstrual cycle is going to occur after ovulation and is known as the secretory or post-ovulatory phase, which encompasses the last half of the menstrual cycle, so from days 15 through days 28. And the secretory phase begins immediately after ovulation, where there's an enrichment of blood supply as well as an enrichment of glandular secretion of nutrients to help prepare the endometrium to receive an ovum that may have been fertilized. Both the menstrual and proliferative phases occur prior to ovulation. Together, they correspond with the follicular phase of the ovarian cycle. The secretory phase corresponds in time to the luteal phase of the ovarian cycle. Let's take a closer look at phases 1 and 2 of the menstrual cycle. Beginning with phase 1, days 1 through 5, the menstrual phase, we can see that ovarian hormones are at their lowest. There's a huge decrease in progesterone, and now both estrogen and progesterone levels have decreased. Gonadotropin levels are beginning to rise. The stratum functionalis detaches from the uterine wall and is shed, and this provides what we refer to as menstrual flow of blood and tissue that lasts for approximately 3 to 5 days. By day 5, growing ovarian follicles are going to start to produce more estrogen. Days 6 through 14 are the proliferative or pre-ovulatory phase. During this phase, rising levels of estrogen prompt the generation of a new stratum functionalis layer, and as that layer thickens, glands enlarge and spiral arteries increase in number. Estrogen will also increase the synthesis of progesterone receptors in the endometrium. This also is a time where the normally thick, sticky cervical mucus becomes thinner, and that facilitates the passage of sperm. Ovulation occurs at the end of the proliferative phase on day 14. This takes us into the last phase of the menstrual cycle, which encompasses days 15 through 28 and is known as the secretory or post-ovulatory phase. This is actually the phase that's most consistent in terms of duration. This is also the portion of the menstrual cycle that the stratum functionalis in the endometrium is going to prepare itself in case the ovulated ovum is fertilized by a sperm. So basically, the endometrium is preparing itself for an embryo to implant. During this phase, we see rising levels of progesterone, which are going to reach their highest level because of the corpus luteum. And those high levels of progesterone are going to stimulate the stratum functionalis to become a secretory mucosa where the endometrial glands enlarge and secrete nutrients into the uterine cavity. We also notice that there is a thicker mucus forming a cervical mucus plug that will block the entry of additional sperm, pathogens, or debris. If fertilization does not occur, the corpus luteum will degenerate toward the end of the secretory phase, and progesterone levels will begin to fall. That will cause spiral arteries in the stratum functionalis to kink and spasm. Endometrial cells will die and glands will regress. Spiral arteries constrict again, then relax and open wide, causing a rush of blood into those weakened capillary beds. Blood vessels will fragment, the functional layer will slough off, and the uterine cycle will start over again as the first day of menstruation. In this slide, we can see the correlation of hormones that is going to accompany the changes that occur with the ovaries as well as the uterus. And you can see in the third chart down, there's a real big spike of estrogen. And that spike in estrogen correlates and is responsible for that surge in luteinizing hormone and follicle stimulating hormone, which is going to stimulate ovulation to occur. And if you look all the way down at the very bottom, you can see the uterine phases, the menstrual phase where the hormone levels are relatively low and stable, and how that changes as we get into the proliferative phase where we've got that spike in estrogen and progesterone starts to climb a little. We've got that big spike in luteinizing hormone and a spike in follicle stimulating hormone as well. And then we see ovulation occur. And then in the post-ovulatory phase, you can see the correlation of the increase in progesterone as well as more estrogen, but definitely progesterone in response to the corpus luteum, as well as how that affects the endometrial lining in the secretory phase. Here we've got a chart on the hormonal effects of estrogen, progesterone, and testosterone. And we can see that estrogens are a class of hormones, and estradiol is the main type of estrogen that's going to be the big player in terms of the female reproductive system. And it lists the sources for these hormones. You can see that estradiol and progesterone are coming from the ovary, with estradiol being produced by the developing follicles and the corpus luteum, whereas with progesterone, that's mainly coming from the corpus luteum. And with testosterone, the testes are going to be producing that, and that's coming from the interstitial endocrine cells, which are found around the seminiferous tubules when you look at those under the microscope. And then in terms of the stimulus for release, we can see that follicle stimulating hormone and luteinizing hormone are going to cause the developing follicles and corpus luteum to release estradiol, whereas luteinizing hormone is going to cause the corpus luteum to release progesterone. And then as far as the interstitial cells go, for the testes, the luteinizing hormone is responsible for stimulating the interstitial cells, which are also called the cells of Leydig, to release testosterone. And then you can see the effects in terms of negative feedback and positive feedback with estradiol, and negative feedback with progesterone, and negative feedback with testosterone, and the effects on the reproductive organs. I'm not going to read this to you. You can read this and see for yourself how that works out. Remember that in terms of estrogen and luteinizing hormone, it's that spike in estrogen that causes that corresponding spike in luteinizing hormone and follicle stimulating hormone that will cause ovulation to occur, and mostly luteinizing hormone. In terms of progesterone, remember that the corpus luteum is what occurs after an ovum has been ovulated. So the corpus luteum is trying to prepare the endometrium for a fertilized egg, which is why the corpus luteum is going to be stimulated to produce and secrete progesterone. That's going to help thicken the endometrial lining. And then with testosterone, luteinizing hormone is going to be important for the production of testosterone, because that's going to help stimulate not only the growth and formation of the male genitalia, but it also is required for spermatogenesis. And remember that androgen binding protein is going to keep the concentration of testosterone high, close to those spermatogenic cells. This slide shows us some more hormonal effects of estrogen, progesterone, and testosterone. Remember that estrogens are a class of sex hormones, and the most dominant one in the female body is estradiol. And we know that estrogen and testosterone both affect female and male long bone growth, respectively. Hopefully that was something that you learned in AMP1, where estrogens tend to stimulate growth at the epiphyseal plate, but then they also stimulate the closure of that plate. And testosterone also stimulates growth of the epiphyseal plate, but it takes longer to close. And that's why men tend to be larger than women. Estrogen inhibits bone resorption because it inhibits osteoclasts. Testosterone does not do that. And estrogen can actually cause feminization of the pelvic bones so that their function can assist with the birth of a fetus. And it also promotes more distribution of adipocytes throughout the female body. Testosterone, again with secondary sex characteristics, that's going to promote growth of the larynx, deepen the voice, and promote hair growth throughout different areas of the body. And the chest, with metabolic effects, they're generally anabolic in terms of sex hormones for men and women. Interestingly enough, the metabolic effects of estradiol are going to inhibit diuresis, whereas progesterone promotes diuresis. And progesterone also increases body temperature Testosterone enhances basal metabolic rate, which is why men tend to have a higher metabolic rate than women. And then as far as neural effects go, both hormones, the estrogens and testosterone, are going to be responsible for libido, which is the sex drive. And know that testosterone is produced in small amounts in women, and estrogen is produced in small amounts by men. And there are different areas of the body that can convert androgens into either estrogens or testosterone. As far as testosterone goes in the female body, the ovaries, the thecal cells that surround the follicles, are actually where the most testosterone is produced in the female body, but the levels are much less in comparison to the testosterone produced by the males. The breasts are reproductive accessory organs that are designed for lactation to produce nourishment for a child when that child is born. The breasts have special modified sweat glands that are known as mammary glands. Mammary glands are going to exist in sac-like spaces known as alveoli in lobules within the breasts. And the mammary glands have special lactiferous ducts that lead to enlarged spaces called lactiferous sinuses. And those lactiferous sinuses have ducts that lead to the nipple, and that's where milk will exit the breast. Now, you'll notice that if we look at the picture on the left, you'll see that there is a pigmented area surrounding the nipple, which is also pigmented, and that area is known as the areola. The breasts also have suspensory ligaments and adipose connective tissue, and in response to estrogen, that can cause the breasts to swell and become tender. And you'll remember there's a spike in estrogen right before ovulation. So that's usually when a woman will notice that her breasts feel more tender and they may be a little bit swollen at that time. When it comes to reproductive system development, remember that when an egg and a sperm get together, each one is carrying 23 chromosomes. So when an egg is fertilized, it now has 46 chromosomes, and 2 of those 46 chromosomes are sex chromosomes. The other 44 are referred to as autosomes. So an X chromosome tends to be large, a Y chromosome is actually quite small, and those are the sex chromosomes. Females have 2 X chromosomes. In terms of eggs and sperm, each ovum always has 1 X chromosome. So it's really the sperm from the male that's going to determine the sex of this developing baby. So males are XY. So 50% of sperm are going to have an X chromosome, and approximately 50% will contain a Y chromosome. When a sperm penetrates an egg, a light is actually emitted, and as that zygote starts to divide and divide and divide, it develops into a structure known as a blastocyst, which embeds itself inside the stratum functionalis of the uterus. And more cellular division continues, and we eventually see that trilaminar disc forming. Hopefully you'll remember that from AMP1, where we have the endoderm, the ectoderm, and the mesoderm. About day 16 of life, the cells have formed an embryo that is sexually indifferent. And that means that this embryo could turn into either a male or a female. So by the 5th to 6th week, the embryo is still sexually indifferent. And at this point, we actually see the beginnings of a future male or a future female. If we look carefully at this picture, you'll notice that there are paramesonephric or Mullerian ducts, and they're located laterally to the mesonephric or Wolffian ducts. Now, the Mullerian ducts are future female ducts. The Wolffian ducts are future male ducts. And the future male ducts form due to the presence of testosterone produced by the SRY gene. There's a sex-determining region on the Y gene, and that will cause the testes to begin to form about week 7 for males. So the gonads actually begin developing around week 5 as gonadal ridges, and there are primordial germ cells that migrate to those ridges to provide germ cells destined to either become spermatogonia or oogonia. And in the presence of this SRY gene, the male ducts will form and continue to develop. In the absence of the SRY gene, female ovaries will start to develop around week 8. So it's that sex-determining region on the Y gene which is only present in males. There are no Y chromosomes in females. So if that egg has an X chromosome, because all eggs do, the sperm, if it has a Y chromosome, will allow for the production of testes around week 7. If the sperm has an X chromosome, then we have 2 X's, and that determines that there's no Y gene, so the embryo will then develop into a female. Next, we're going to discuss sexually transmitted diseases, beginning with Chlamydia trachomatis, which is the most common bacterial sexually transmitted infection in the United States. This can actually be contracted from the birth canal by newborns and is responsible for anywhere between 25 and 50% of all diagnosed cases of pelvic inflammatory disease. The symptoms include urethritis, penile or vaginal discharges, abdominal, rectal, or testicular pain, painful intercourse, or irregular menses. Only 20% of women and 10% of men have symptoms. That means that people can have this infection and spread it while not realizing that they're infected. If left untreated, chlamydia can lead to sterility. Newborns who may contract chlamydia from the birth canal can potentially develop conjunctivitis, which is a painful eye infection that can lead to scarring of the cornea if it's not treated. They could also potentially develop respiratory tract inflammation and infection, including pneumonia. So the treatment for chlamydia is a course of antibiotics because it is a bacterial infection. Next, in terms of sexually transmitted diseases, we're going to discuss gonorrhea, which is a bacterial infection of the mucosae of the reproductive and urinary tracts, caused by the bacteria Neisseria gonorrhoeae. Most infections are asymptomatic, which means people can be infected and spread them without realizing that they're spreading it. In males, symptoms can include urethritis, painful urination, discharge of pus from the penis, which is known as penile drip. If left untreated, gonorrhea in males can cause urethral constriction and inflammation of the duct system. In females, gonorrhea symptoms can include things like abdominal discomfort, vaginal discharge, abnormal uterine bleeding, and possible urethral symptoms. If left untreated in a female, that can lead to pelvic inflammatory disease and possibly sterility. The treatment for gonorrhea is antibiotics. Unfortunately, resistant strains are becoming more prevalent. So now they have to treat with at least 2 different types of antibiotics to try to rid the person of this bacteria. Syphilis is another bacterial infection that's transmitted either sexually or congenitally. Syphilis is caused by the bacteria Treponema pallidum, and infected fetuses can be stillborn or even die shortly after they're born. The bacteria invades the mucosae or even broken skin. The infection is usually asymptomatic for the first 2 to 3 weeks, and then a painless chancre will appear at the site of infection. A chancre is something that kind of looks like an ulcer, and even though it's not painful, they tend to be weepy, so there's going to be some clear fluid coming out from this painless sore. And unfortunately, that's where the bacteria is, in that clear fluid, so it's highly contagious. That chancre will disappear within a few weeks. If untreated, a secondary sign will appear weeks later, and that could occur in the form of a pink rash or a fever, even joint pain, and that usually occurs and appears for about 3 to 12 weeks, and then it will disappear. Then syphilis will enter what's known as a latent period, which may or may not progress to tertiary syphilis. Tertiary syphilis is characterized by gummas, which are lesions that develop in the central nervous system, blood vessels, bones, and skin. And the treatment for syphilis is penicillin. Human papillomavirus includes a group of approximately 40 or more viruses and is considered the most common viral sexually transmitted infection in the United States. Over 50% of adults are going to be infected during their lifetime, and this is the cause of genital warts. About 80% of the cases of invasive cervical cancer are linked to some type of strain of human papillomavirus, and they can also be the cause of some penile, anal, or oropharyngeal cancers. So vaccination can guard against most common cancer-causing strains, and it's a shot that's usually recommended for boys and girls before they become sexually active. Herpes is caused by the herpes simplex virus, and it's one of the most difficult human pathogens to control because most people don't even know they're infected. Only 15% will display some type of infection sign. These are characterized by latent periods and flare-ups with the formation of vesicles and can be passed on to a fetus. Congenital herpes can actually cause malformations to occur in developing babies, and the treatment for herpes is usually with antiviral drugs that can reduce the duration and intensity of the flare-ups. This is our last slide, and in this slide we're going to discuss hormonal birth control. This takes advantage of the negative feedback system because with hormonal birth control, these chemicals provide constant levels of estrogen and progesterone, inhibiting the release of follicle-stimulating hormone and luteinizing hormone. So the follicles don't mature, and endometrial lining thickening is minimized. Skip doses can lead to ovulation, so it's important that if a person is using any kind of hormonal birth control, that it is administered on a regular basis in conjunction with the type of birth control that it is. Some injections require annual administration. Oral doses require a daily administration where there is a placebo that's given so that a menstrual cycle can occur. Ovulation won't, but the sloughing of the uterine lining can occur with oral medications. And that is the end of the male and female reproductive systems. Thanks for watching.